I'm going to have, and Maggie, I believe we have about 15 minutes for my portion of the conversation. Is that correct?
Yes, correct.
Okay, thank you. And then I'm going to just briefly get into also talk about the fact of the social and medical injustice that have occurred to underserved communities and how that fact leads to a lot of what we see around vaccine hesitancy, and then examine some of the myths related to the COVID vaccine, and then identify ways to overcome justified vaccine hesitancy through some honest and open conversations. So facts about mortality rates. Many of you all have seen these maps before, and these maps consist of the 77 community areas in Chicago. And one of the things that you will see is that mortality rates, again, are death rates. This is as current as January 22nd. So I've highlighted two communities for you here: 60626 in the north part of the city, and then 60649 in the south part of the city. And then look at these clustering of zip codes around 60654, 60607, and that area. And I want you to pay attention to, this is where more people are dying from COVID-19 in certain communities. And if I were to take this map and do a map on race and ethnicity in the city of Chicago, what you will see is that many of these communities are your Black and brown communities. Many of these same communities, if Dr. Simon was talking about some of the work that she does in maternal health outcomes, many of these same zip codes, this same map will look very similar to what we see in terms of birth outcomes. If we were talking about asthma outcomes, this same map will look very similar in terms of, so the same community areas that are being impacted by higher death rates due to COVID-19 are also some of the same community areas that are impacted by other health disparities, including cancer, which the Chicago Cancer Health Equity Collaborative is trying to adjust. So lock this image in your head, and now look at this. This is a map that talks about where testing is taking place throughout the city. So this is a percent tested by zip code. So if you just look at the 60649, it has some of the lowest tested communities, but then look at that cluster where you see some of the, so compare again this one where you saw that cluster, those zip codes that have the lowest mortality, and compare that to where you have some of the highest testing. What we know is that testing is one of the things we need to continue to do to ensure that our Black and brown and underserved communities are able to know, do I have the disease? If I do, how can I take proper precautions to social distance as much as that may be allowed, and take the precautions to make sure that I'm protecting myself? So until this map, the testing map, needs to reflect the mortality map. And until that happens, we know that fact is going to continue to lead to some of the disparities that we're continuing to see. So I now want to switch to this conversation about vaccine hesitancy is rooted in justified historical mistrust. What do I mean by that? And I could give a whole talk about historical mistrust. This narrative is actually pulled directly from the CDC site. The Centers for Disease Control and Prevention has a site that's called cdc.gov Tuskegee timeline. And what they do in this study, in this site at the CDC, is they walk you through some of the historical misgivings that have happened in our nation. And I'm sometimes reluctant to talk about the public health service study that happened in Tuskegee, Alabama. But for today's conversation, I want to root it in a fact that has happened that leads to a lot of the vaccine hesitancy. And then, so what happened? So in 1932, the Public Health Service, working with Tuskegee Institute, began a study to record the natural history of syphilis in hopes of justifying treatment programs in Blacks. It was called the Tuskegee Study of Untreated Syphilis in the Negro Male. This study went on for over 40 years, you all. And then in 1972, an Associated Press story about the Tuskegee study caused a public outcry that led the Assistant Secretary of Health and Scientific Affairs to appoint an ad hoc advisory panel to review the study. This finding that happened in 1972 is really important because this led to the fact that now what exists is certain things are in place to ensure that nothing like this happens again, to ensure that we have institutional review boards, IRBs, to ensure that we have the FDA that controls that oversees all clinical trials to ensure that things like this doesn't happen. And the other thing that happened was that the Centers for Disease Control and Prevention was given responsibility for this program and other programs like it, where it remains today in the National Center for HIV and AIDS, Viral Hepatitis, STD, and TB Prevention. And the last study participant from this historical study, this is an important fact, died in January 2004. The reason I bring this up is because when we talk about historical trends, we talk about them as if many of us would not know any of the people in this study that led to some of this medical mistrust. But the reality of it is that the last study participant died in January 2004, and the last widow receiving some of the benefits of this study actually died in January 2009, and that there are 11 offspring currently receiving medical and health benefits from this study. Why do I start talking about this study? And if you know me, and you know that typically, sorry, I don't like to actually talk about this study because I think it leads to a lot of the misgivings of medical mistrust. But what I want to talk about is the fact that this study did happen, and it was conducted by the public health. It was conducted by our federal government. I was on a call. I was actually on Zoom Church on Sunday. And after our church service, we have these things called virtual social hour, where when we were in person going to church, this is when we used to go into our community room and you talk to your other congregation members. So now we do it virtually. And one of my colleagues at church actually said, well, Karriem, I don't understand this vaccine hesitancy. And I was floored. I was like, have you not been listening to everything that's happened to Black and brown communities over the last 70 years? And a lot of what's happening is rooted in a lot of this information. So next, I'll talk about the fact that COVID-19 vaccine hesitancy, another fact is that it's connected to overall vaccine hesitancy. So we didn't just start talking about vaccine hesitancy as related to COVID-19. This has been going on for a while. And so images I have on the screen here is that many of you all may recall back in 2015, there was a measles outbreak in 2015 that was actually related to incident. And it was actually highlighted because there were some visitors to Disneyland at that time in California, and they did what's called contact tracing. So this whole concept of contact tracing, it's not just new to COVID-19. Contact tracing has been happening for years and decades. And some of my colleagues at Howard Brown are leading some of the efforts in contact tracing. And the reason why people like from Howard Brown are leading this, because Howard Brown is a federally qualified health center who's been doing work around sexually transmitted infections and sexually transmitted diseases for decades. And so they know how to do contact tracing, because what they've done at Howard Brown, that they've adopted their model for when they used to call and try to identify patients who have been impacted, by HIV and AIDS. And you had to call and work with the CDC and work with the Chicago Department of Public Health to find who have been your partners, who also may have been exposed. That's contact tracing. So it's not one thing we've done public health has done not so good of a job of, is letting the community think that the things that we're doing now related to COVID-19 are things that we just started. We have known how to do contact tracing for years. If you're an epidemiologist, if you work in public health, this is actually kind of part of your training even, to understand how to have a conversation. It goes back to when we think about what happened in Great Britain when we first followed the cholera virus. When we found out where cholera happened, that was kind of contact tracing, going back to Broad Street, looking to see where that water, who had that water, who had been contaminated by that water, who drank that contaminated water supply. That was part of your old school contact tracing. The other thing that this vaccine hesitancy is linked to is myths. There are these myths that vaccines are related to things like autism. That has not been grounded in science. There have not been evidence-based scientific studies that have shown that vaccines are connected to autism. But unfortunately, we've had a lot of stars and celebrities who have a platform. And I used to love her when she was on one of my favorite shows, The View, as one of the co-hosts. And I still do love you, Jenny McCarthy, but you got this one kind of wrong. You got this one wrong when you were talking about vaccines being linked. And I love you, Jenny. And she's you're part of the Chicago crew, the Midwest crew. But on this one, it wasn't rooted in facts. So I'm not going to say Jenny was wrong because I don't want to be a part of cancel culture. But I am going to say that some of the dialogue that has been happening has not been rooted in evidence-based scientific studies. Please don't come after me if you're a Jenny fan. Just know that this is all in love, but just got to, the truth is the truth. And so what we do know is that the studies that people have used to talk about some of the things that have been related to vaccines have not been rooted in science and have not been grounded in evidence-based data. So the other thing that has happened that's a fact is the politics of vaccines. This is not a partisan slide. This is actually to let you know that unfortunately, those of us in public health and science, we've been robbed of our platform to talk about health in this bipartisan way. Health and public health is not a right-wing or a left-wing discussion. Health is a social justice issue that should be talked about no matter what your political party or affiliation is. And unfortunately, what has happened was that the COVID-19 virus and subsequently the COVID-19 vaccine, the conversation was hijacked by a political conversation. So those of us that are public health advocates, we're taking the conversation back. We're taking the conversation back. We're bringing it down to make it a public health conversation and not a political conversation. So this is not about us saying this administration got it wrong, this administration got it right. This is about us saying that vaccines, COVID-19 vaccines and other vaccines are a public health issue, not a political issue. Now, I will say it's a policy issue though. And so what we do need are policies in place to ensure that all communities have access to vaccines and testing despite your ability to pay for that. You should have access to the vaccine despite whether you have insurance or not. So those are policy issues. And so when you think about public health, think about policy, not politics. That's one of the things I want you to walk away with today. Public health is about policy, not politics. So the other thing before I finish up is that I want to talk about the hesitancy in the COVID-19 vaccine study has been linked to this issue, which is the fact of the previous lack of diversity in clinical trials. For example, we know that a fact is that typical African Americans typically make up less than 5% of clinical trials. That's a fact. That African Americans make up less than 5% of clinical trials. Another fact is that studies that have been done, and one of my areas of research is in tobacco cessation and lung cancer screening so my work goes across a lot of different cancers. But some of the work I'm doing now through the Chicago Cancer Health Equity Collaborative is looking at lung cancer screening and tobacco cessation. A fact is that the current guidelines that we have for lung cancer screening were developed via studies that were done in 33 sites across the US. And of those 33 sites, only 4.4% of the participants in those clinical trials were African Americans, despite the fact that Black men particularly are leading the nation in terms of death related to lung cancer. So a fact is that those that are often impacted by conditions aren't always the ones involved in clinical trials. Why is that? That's because the clinical trials aren't always conducted in the places and spaces where more Black and brown and underserved communities live. So we have to do a better job of ensuring that clinical trials are conducted in the very spaces and places where communities are carrying the burdens of disease live. So I'll end with this, talking about the Pfizer study. This is a fact, people, so help us get this information out there. And please go to www.fda.gov you can download this information. So this information I'm going to give you today, it's all public. So those of us who do research, when we get our data, we don't have the ability to fudge that data or come up with false data, because if you do, everything we present when it becomes part of developing a new drug or device, that actually goes to the FDA and becomes public data. So what do we know about the Pfizer study? The Pfizer study is now used for the Pfizer vaccine. One of the many vaccines has now been FDA approved. So for the study included 49.4% women. That's important because too often, many studies actually in the past have not included women in those studies. Fact, 81.9% of participants were white participants. That does not mean non-Hispanic or whites, but 81.9% were white participants. 4.4% were Asian participants, and less than 3% from other racial ethnic groups. 26.2% of the participants were of Hispanic and Latino descent, and 21.4% were greater than 65 years of age. And the median age of the study was around 51. What did the participants in the study look like? They had comorbidities and things similar to what we have. Many of them were obese, 35.1% were obese, 8.4% of them had diabetes, 7.8% of them had pulmonary disease, and 76.7% of the participants were from the US. Because that's another myth that I've heard, was that, Karriem, well, you're promoting this vaccine, you're promoting this research. This research didn't even happen in the US. That is a myth, you all. The majority of the participants in this vaccine study were 76.7% of them were from the US. So the fact, that myth that you're hearing circulating out there, that this study happened outside the US is not true. Moving from myth to fact. So one of the things is that we have the other issue of diversity in clinical trial is the fact that we often don't have people asking the question that looks like the population that are impacted by the disease. So I want to talk to you about two of my favorite heroes in this work, both nationally and locally. So one of my national heroes in this is Dr. Kizzmekia Corbett. Dr. Corbett is a senior research fellow and a scientific lead on the coronavirus vaccine happening. She is an African-American woman, a scientist who, beyond COVID-19, you all, her work didn't just start with COVID-19 vaccine. That is not what, she is a immunopathogenicist looking to identify other vaccines related to viral pathogens. Her work started long before COVID-19, and she is one of our leading scientists leading this work. That's happening nationally. And the other thing that's happening locally is one of my own colleagues and friends, Dr. Marina Del Rios, was one of the first people in Chicago to receive the COVID-19 vaccine. And Dr. Del Rios is doing work both through community outreach and engagement to ensure that people in Chicago get access to testing as well as the vaccine. And she's leading a lot of these efforts in our Latinx communities. And so I wanted to end with these two images because too often the messages that we hear don't come from the communities, don't come from messengers that look like the populations that are carrying the greatest burden of disease. So I'll stop here because I know we're going to have a lot of questions as we go into after we go into Dr. Simon's talk. But one of the things I didn't have time to put in this slide is about emergency use authorization, the EUA. So what you all have heard, and Dr. Simon is going to talk about that. So she's giving me a signal that she got me covered, as she always does. So I'm going to turn the floor over to her. Thanks so much, you all.
Thank you so much, Dr. Watson. I think, Dr. Simon, you might be muted, but you are more than welcome to take the floor when you're ready.
I'm ready. All right. Y'all see my slides? Okay. Now, I put a lot of stuff on the slides because I don't believe in dumbing down the science to community. So I'm piquing the interest and the curiosity because I know we don't have too much time, but I want you to pique your interest and curiosity and write down a question to ask us or to ask us later. I am a full supporter of us reconvening at another time next month or in a few weeks to answer more questions, because there's so much stuff here that's important for you to understand and to get you to be comfortable and your community members to be comfortable with getting that vaccine. Because we got to get to a yes. We got to get to, and not just a yes, we got to get to the needle in the arm twice for some of the vaccines and once for maybe some of the ones that may be coming down the pike to be approved soon, hopefully. So I just, again, want to acknowledge Dr. Watson did an outstanding job as always. So proud of him and to get to have the opportunity to work with him. for a very long time now. We have lots of pandemics going on. Racism, COVID-19, distrust that we've earned in the darn healthcare delivery system, and misinformation galore, all right? And he's right that, you know, when I take care of a patient, I don't care if you're red or blue or who you voted for. I want to help you get to the best health possible. I also, in addition to being an OBGYN and a primary care doctor and a scientist, I also was an epidemiologist in the Chicago Department of Public Health way back in the day, in the mid-90s, with the heat deaths. And a lot of this contact tracing and all this stuff that we've done, it builds on all those years of experience. So I just want to acknowledge that. So COVID-19 and vaccine technology. So what is a vaccine and how does it work? Okay, these are hard slides, but I just want to give you the overview. All right, a vaccine is a type of treatment designed to protect against infectious diseases by introducing the body's immune system to something. Now, the something could be a piece of the virus, or the bacteria, or it could be the mRNA, the messenger RNA, which helps promote the body's immune system, because we have warriors in our body that are ready, willing, and able to attack the people who are the things that are invading it. So we have an army that is just at our disposal. Our body is an amazing thing. And our immune system really can learn and devise strategies to defeat it, right? And so usually what happens is they provide, our body creates antibodies to proteins, okay? Those things that are being introduced that are bad to a specific disease to attack it. So then when you get that vaccine, the next time you see, your body sees that offender, it's like there's wanted signs put up all around inside your body. And those wanted signs go, okay, we got it. Let's get our army mobilized. This is the person, this is the thing we have to attack. And they go for it and they attack it. So here's a picture. So I just gotta move this out of the way. I don't know how to move this out of the way. In any event, oh, how did that happen? So you're vaccinated against a specific disease. It could be flu, it could be tetanus, something, all right? And basically you get the shot in your arm, you see the number 1 there, and then what happens is that whatever's in that shot, and it's something that, again, like I said, it could be a piece of a bacterium or something, a messenger RNA, like for the Moderna and Pfizer COVID vaccines, that trigger your body, and number 2, to produce something, to look at it and then produce B lymphocytes that can detect those antigens. Those antigens basically that you're getting are basically the wanted signs that say that's the thing that we don't want in our body. We need to attack that. So your body starts to learn, and it makes all these different cells. You see the memory B cells and the antibodies and all that stuff, all number 4, 5, and 6 to attack. That's the army, okay? Getting ready to be mobilized. Then you get exposed to that real infective organism. So after you get the shot, right, or the 2 shots, the vaccines, and you get exposed to COVID, for example. And that spike protein, for example, is what your body learns to make. And some doctors and healthcare providers call it the gangster spike protein, right? It goes into your body and your body goes, yo, those spike proteins are bad. We can attack them, and we've got to. And so your memory B cells, those army that you have great memory. And they look at that spike protein as the offending agent and they attack it. And that's why when you get this vaccine, your body can prevent you from getting COVID badly or at all. So clinical trials are important. I want to emphasize what Dr. Watson said, that these vaccines that are getting FDA approval are already in that yellow category on your screen. There's been phase 1 where only 20 to 80 participants actually received the first experimental part. So they were the first bravest people to get those vaccines in their body. Then it went to phase 2 where there was 100 to 300 participants. And then it went to phase 3 where there was far more than just 1,000 to 3,000 participants. There was like tens of thousands of participants. And then we got the FDA review to confirm safety and effectiveness. And we don't stop studying these vaccines. We're actually in phase 4 now for Pfizer and for Moderna, because what we have to do now, we only got an Emergency Authorization Act. That's to use the vaccine because we know it has a high effectiveness, a high efficacy and safety profile. But we still need to keep studying it to make sure that there's a longer term immunity to protect you for who knows how long, or if you need a booster after a year, we don't know that. So all of that information, and also in phase 4 is when we open it up to younger people, to pregnant people, potentially to lactating people, more people. So we need the COVID vaccine because masking isn't enough. Washing your hands isn't enough. Social distancing isn't enough. And we all know that we've got to get back to closer to normal, right? Because of the economy, getting jobs back. I have 4 children, getting kids back in school, all of these things. And the only way to get beyond this pandemic is to get immunity and herd immunity, which means about 75% to 80% of the population around the world needs to be vaccinated, right? And to have immunity against this virus. So there's lots, this is a very busy slide, so don't worry about it. But I just want to show you that there are a lot of different types of coronavirus vaccines being tested around the world right now. Obviously the RNA ones, the BioNTech, Pfizer and the Moderna are the RNA vaccines, where this far left-hand side, where you have RNA molecules, your messenger RNA, not your DNA. It does not get into your DNA. It does not go into your cells. It does not change your cells at all. This is a type of vaccine that is a newer type of vaccine, but highly effective from the trials. And so what it does is, here's the example of the Pfizer. This is the coronavirus on the left, that spiky thing in the red. And so that's that spike protein I talked about, that gangster spikes protein. And basically what it does is this vaccine takes a spike protein, right? And it encapsulates it into a donut, basically. Some lipids, some fat, right? Because you need a little sugar, all right? There's no animal products. There's nothing like that. And that's really important because I know that some religions do not want animal products in their vaccines, right? So it's encapsulated in a donut, all right? There's no calories. Don't worry about that for those of you dieting. And it goes in this mRNA that's in this package, this little spike protein is packaged. And it gets into the cell to teach your T cells and your B cells, right? Your army, your immune system in your body to multiply and to be ready for when they see another spike protein come into your body. So the next time that they see that spike protein get into your body, they start to multiply like crazy. And that's why your lymph nodes can get swollen and they're around your body. And basically what that's saying is that your body's fighting that bad spike protein, which the coronavirus, that's the marker of the coronavirus. So safety of a vaccine means when comparing the vaccine and the placebo groups, are there any side effects or adverse events that are disproportionately experienced by those who receive the vaccine? And if no, then safety is acceptable. And that's what the the FDA and the CDC were reviewing. And efficacy means when comparing the vaccine and placebo groups, do those who receive the vaccine experience fewer cases of symptomatic and severe COVID-19? And the answers were yes, for both Moderna and Pfizer. And we think that the Johnson & Johnson vaccine, which is just one shot, may have very good favorability profiles, but we don't know yet. That data is going to be released soon, I think. The emergency use authorization that Dr. Watson was referring to, it can only be issued if these trials were good. There was no way that the EUA, the emergency use authorization, was going to be allowed to move forward if the safety and efficacy profiles of Pfizer and Moderna vaccines were bad. All right, so there was a lot of review, a very heavy and deep review that was required. And the EUA required a determination that the known and potential benefits of the vaccines outweighed the potential risks. And that was really important. It's still, this EUA though, makes it so that we cannot mandate the vaccine. All right, we also, so that means people have the option to refuse, but our goal is definitely to get to herd immunity. It's a really important thing in order to move beyond this virus, this pandemic. Again, the CDC has the ACIP, which is the Committee on Immunization Practices. And they also had to go through and review all the data on both of these vaccines once the FDA gave the emergency authorization approval. And basically what they went through is looking at, should COVID vaccine be recommended, right? And what's the evidence? And they poured through all of that evidence. And it was a diverse panel of people from many different expertise, different racial, ethnic backgrounds who were reviewing these data, both at the FDA level and the CDC, ACIP levels. And so those were really, really important things. So the objectives were really to ensure safety and effectiveness of the vaccines, and that would help us lead to reduced mortality and morbidity, because we know our Black and Latinx populations and Indigenous populations in this country are being hardest hit, and not only hardest hit, but at younger ages, which means more of our communities are dying at a younger age. And so that's what makes this whole process so essential. In addition, for those who are getting vaccinated, there is a vaccine safety data link. And basically this is a program by the CDC that you put in on, you can download the app on your smartphone, for example, and every day after you receive the vaccine, both doses, you can monitor your safety, your profile. If you have any symptoms like pain at the injection site, or you're feeling a little under the weather, or if you have chills or things like that, you put it in, and the CDC is monitoring all of us for any adverse reactions. And far and wide, over our centuries of understanding vaccines in general, the highest, the time of where you'd see the most adverse reactions or problems is about 30 to 40 days out from vaccines. So like I was one of the first, right after Marina, Dr. Del Rios, when she had her vaccine, I got mine a few days later. So I'm now more than 14 days out. I'm like 17 days or something out from my second vaccine of the Pfizer. I received the Pfizer one. And I'm doing fine. But you know, if something is going to happen, it's going to happen either immediately after getting that second dose, or the first dose, and then, or 30 to 40 days out from the second dose. And so by the time most people are going to be getting their vaccine, we will have a ton of data across many diverse people across the country for possible adverse reactions. We'll have a lot more data because we're collecting it as we move forward. So things like pain, erythema, swelling at the injection site, fever, headache, muscle aches, those things are the most common side effects reported for the Moderna and the Pfizer vaccines, mostly after the second dose. Less symptoms after the first dose. And again, just like Dr. Watson said, there were diverse people in these trials. And again, he already gave you the data. These are the data from the website, from the studies. They tell you before you get your vaccine to make sure you tell them about any allergies you may have. If you have a fever already, if you're on a blood thinner, if you're immunocompromised, if you're pregnant, if you're breastfeeding, or if you've received another COVID vaccine, just get one. You don't need to get the Moderna and the Pfizer. Just get either the Moderna or the Pfizer or the other ones as they get approved. Now, I'm an obstetrician, so I actually would say for pregnant persons and breastfeeding persons, there is no concern with these two vaccines. There are very little data right now in them, but if you are in a healthcare worker or essential worker position where you are exposed to COVID-19, you have a higher risk of getting COVID-19. And if you get COVID-19, you have a higher risk of getting hospitalized and potentially intubated. And so we know that it is better if you are exposed or in a job that puts you at high risk and you're pregnant or lactating, then you should really consider getting the vaccine. Again, what we don't know, safety and efficacy in certain groups. Young children, we don't know. They are enrolling age 12 and up now in Moderna and Pfizer. So we're going to have age 12 and up. And there will be more data on pregnant persons and lactating persons as we move forward now. We don't know how long immunity lasts. We don't know if you need a booster. They are considering Moderna getting a booster because of some of the variants that are out there right now. That's another thing. The longer we wait to vaccinate people, the more variants that are going to produce, because viruses are smart. They know how to change and they can alter and they can get more virulent. So that is why it is important. Another reason why we need to vaccinate. We can talk about this as in our discussion. Again, vaccines aren't going to save lives. We actually have to get the vaccine in people's arms. We absolutely have to. And it is 100% voluntary. There's no workplace that can mandate this at this point because both vaccines are under an Emergency Authorization Act. And so distribution is important. We have these phases, and the reason why these phases from the CDC were developed is to try to get more of an equity framework, because we don't have that many vaccine doses available at this moment, but our new administration is rendering them as much as and purchasing them as fast as they can. So right now, Chicago is in 1B. And so hospital, and just because we're in 1B doesn't mean if you're in 1A, you can't get the vaccine. It just means that we're going down the list, and if you didn't get your turn, you didn't get a chance yet to get that vaccine and you're in 1A, you could still get the vaccine, right? So I want to emphasize that. So frontline workers, essential workers, healthcare workers, food service workers, transit workers, teachers, people in workplaces, congregate or overcrowded settings, people ages 65 and older. So at first, the recommendation was 75 and older, and now it's 65 and older. And that really speaks to the younger ages at which our Black and Latinx and indigenous communities are getting COVID and having bad outcomes. So that's really important. We also are working with the local Chicago Department of Public Health and Illinois Department of Public Health to ensure that there is distribution and that it starts happening in a more effective and efficient way. And returning to normal, we really need herd immunity. And so just because you get the vaccine doesn't mean you take your mask off, because we don't have phase 4 clinical trial data yet. That's why we have to wait and keep the vaccine and the social distancing and the hand washing up. So we really do need to get the 75 to 80 to 90% of the population vaccinated globally. All right, I'm going to stop there.
Thank you so much, Dr. Simon. That was such great information. I know that we just threw a lot of information at you guys. So thank you everyone for listening in, and I will turn the floor over to any questions that any participants have. I know we do have. some questions, but go ahead to whomever would like to say.
I had a question. I'm Dolores Castañeda from Little Village. And the community asked me to ask some question. They want to know when is possible, when is the vaccine is going to come to the community. I see that who is going to be first and next, but the concern is about bring the vaccine to the community and churches, schools, close to the people can access easily.
So
Yeah,
okay,
go ahead. Go ahead.
Thank you so much, Dolores. One thing is that I'll speak on as a federally qualified health center. So as a FQHC, we're getting our supply from the Chicago Department of Public Health, which is getting from the Illinois Department of Public Health. And so we'll be using a new vaccine. Dr. Simon talked about with the Pfizer, but we'll be using the Moderna, which has also been a part of the recently FDA approved vaccines. That will likely happen in community settings, still starting with patients that are 60. So let me back up. There's community members now that reach certain age that can get it, that if you are a patient and you are 65 and older and you are a patient that's an essential health worker, you can get the vaccine right now at many places by going. The challenge is that, and I will be very clear, it's difficult to register online. It's not a user-friendly process, and they are well aware of that, but that is the current mechanism, is to go online and get that information. The other thing that will happen is that federally qualified health centers will start dispersing it sometime around the second week of February. I don't want to throw out a date because we don't know for sure, but we should be getting it in our community clinics around the second week of February. Dr. Simon?
Yeah, thank you. I like to be part in the campaign when I wanted to be part in the community to advertise vaccine and everything. The other question is about when is it possible to get more education about the vaccine, how to prepare the community, maybe make infograms and put in different spaces and laundry places, store. I wanna be part in doing that, because that way that people feel more comfortable to get the vaccine when we're ready. Thank you.
Dolores, I agree. I couldn't agree more. And so, for example, I'm a part of what was mentioned earlier that Dr. Del Rios is a part of. We're both founding members of the Illinois Unidos, which is the statewide Latinx response, where there's 170 of us on that thing. And a small group of us, the healthcare providers and health policy people, we've done a series of infographics already around COVID-19 in English and in Spanish, but there's more. So we're developing the ones around the vaccine as well. And we're doing a lot of town halls, like I mentioned in the chat, tomorrow, ABC 7. Like we were on WTTW 2 nights ago, or last night, one of the Monday or Tuesday night. But tomorrow at 2 p.m. we'll be on ABC 7 again for town hall for the vaccine. So we're trying to get this information out. But I will acknowledge what Dr. Watson said, the rollout right now is hard. It's been rough with respect to, there's going to be a ZocDoc enrollment online. They are working right now on more mass areas to go and get vaccines, more like pop-up areas where they're trying to do mobile vans or mobile units for vaccination as well. So there are a lot of moving parts right now being considered and different strategies being considered to make sure a community that is eligible for the vaccine can get it. And that's definitely a huge concern and a big issue that they're talking about right now. It will be easier. So if if Johnson & Johnson gets approved, it will be easier because it's one dose. Okay, that's the big difference between Moderna and Pfizer and Johnson & Johnson. Johnson & Johnson is one dose. Moderna and Pfizer require 2 doses. And if you're late, I saw a question in the thing, if you're late for the second dose, it's okay, there's a window. So we think right now, again, we don't have all the data in the world, we need more data, but at least 6 weeks between the two could be okay. There's also some thought that you could mix and match the vaccines as well. But for now, if you get Moderna, get the second one that's Moderna. And if you miss your appointment, just get it as soon as you can. And that's an important point.
Dr. Simon, there's a question in the chat. I think that's one of your slides. You did such a great job about the spike protein. And I think that question can be answered it's really more about, it specifically says, can you discuss more about what happens after the vaccine enters your body? And I think the bigger question there is, I don't want to reframe it, but just really talking about the difference between an allergic reaction versus an overactive immune response.
Yeah, I mean, that's the technology of any vaccine. So any vaccine, and I have to emphasize, we've been doing vaccines and they have been inordinately, predominantly super safe for years, tens and tens, I mean, decades and decades and decades and decades. And so we have really good technology to make sure that your body, whatever we're injecting, the amount that we're injecting your body gives just enough response that does not cause an allergic reaction. All right, rather it causes your immune system, your body's natural army, to produce what needs to happen for when you get hit with the disease or presented with the disease after you get the vaccine. And it's a different pathway for an allergic response versus immunization response for a vaccine.
And I really like the way you framed it, talking about that. Like I put in the chat, yesterday after I had my second dose, I communicated with my primary care provider who had educated me on some potential side effects. And I did. I had the muscle aches. I felt a little cold-like symptom. And he was like, thumbs up, your immune response, your body's doing what we want it to do. But had I not had a conversation with my doctor about what to expect, I could have bought into some of those myths that, oh, the vaccine made me sick. The vaccine did not make me sick. I had a normal immune reaction to it, but we were looking for things like making sure there was no rash at the injection site, making sure I had no difficulty breathing, and I had none of that, but I did feel a little bit for a day, but you bounce back.
Yeah, and that's not to say that if you don't have a reaction that you didn't get the immune response, because most of my colleagues and my friends who received the vaccine so far did not have any response.
That's another myth that you're busting. That's right.
Right. And so I wouldn't worry about the response. Just, if it happens, it happens. For those of you that are worried, right, about an allergic response, it would happen right within the first 15 to 30 minutes of getting either the first dose or the second dose. And so there will be at every vaccination site an area for you to sit and wait if you're worried. And you wait for those 15 to 30 minutes and then you're fine. So again, I want to emphasize that this is newer technology of the mRNA technology, but it has been tested on a whole lot of people.
So I'm sorry, I guess the question wasn't answered. It's a more specific question about the mRNA. I meant more on the science side. If mRNA produces the spike protein on the membrane of our cell, would the immune system attack our cells, or does it just recognize the protein?
It just recognizes the protein. So it's that spike protein that's very, very characteristic of the coronavirus. All right, so that spike protein, so it was so the vaccines were purposely designed to target that spike protein because that spike protein is so specific to coronavirus. I hope that answers your question a little bit better.
Okay, I'd like to ask a question, please. We now have 3 vaccines, one that has to be stored at such cold temperatures, I'm just not understanding. And now we have one where you only need 1 dose instead of 2 doses. And then I read that if you're on blood thinners, then this might not be a good thing. For those of us who are not medical doctors and public health officials, when you see all of this information, it becomes confusing. And it I'll speak for me, makes me hesitant because it doesn't seem that everybody's talking to each other. You're just creating this vaccine and everybody's running. So if you could give me a little more on that.
Yes, Ms. Jackson.
Thank you.
Ms.
Thank
Jackson,
you.
that's a great question. So I want to back up and say, for the flu shot, there are tons of different flu shots. There are several companies that manufacture flu shots. They don't come from just one. There's different science that was behind each one, and most of us don't know which one we're getting. There's even a sniff one. I know that like my kids get the flu mist, which is different than the flu shot, but it still serves the same purpose. So I want to first frame it that way, that we actually need lots of, because of the number of people on our planet and just in our country alone, we actually need many companies to be able to develop vaccines. The other important part is there are only 2 vaccines right now available. The third one may be available, but we need to wait for them to present, the company to present their data to the FDA to get emergency approval or emergency use authorization. So there are only 2 right now, and they both use the same technology. They both use mRNA technology, and they are the Moderna and the Pfizer. And you're right, they require different storages. And that's because they cooked it a little different. The way I see vaccine development, it's like cooking. So, you know, when I watch the cooking channel, it helps distract me sometimes.
I do too.
Yes, yes. And for instance, look, I'm Mexican, the mole, all right? We all make our mole different. Some of us obviously use a jar, but me, but every mole has a little different. But the outcome is the same with respect to its mole, okay? And it's right. I know this is not a perfect analogy, but the point is when we cook the vaccine materials to make the vaccine, both of these Moderna and Pfizer vaccines have that spike protein. But what they use, the donut that I described earlier, the lipids, the fats, and the sugars, what they use to capsulate it was a little different. It's like Do-Right Donuts and Dunkin' Donuts versus Stan's Donuts, right? They used it a little different because they couldn't do exactly the same thing. They're different companies and they need to produce this, but the outcome needed to be the same. And so the outcome was actually very similar. So about 94 to 95% efficacy in outcomes for both Moderna and for Pfizer, but they cooked it a little differently. The same spike protein, it's just one used a little more sugar, one used a little more fat, and that was it. I hope that makes sense, Mildred. And so because they cooked it differently, they have to store it differently. So Pfizer requires -80 and storage, which is super, super cold. And that's why you'll see it being administered more in a hospital-based setting, because it's harder to keep that freezer, that temperature. But the Moderna requires -20, which is what many flu shots require. And so it's easier to mobilize Moderna's vaccine in the community. And then if Johnson & Johnson does get approved, it's 1 shot, and it will be even easier to mobilize that in the community.
And then the thing about the blood thinner, what is that?
So again, anytime you get a shot and you or are going to get a shot and you're on a blood thinner, we want to know, because you could get a bruise or a hematoma, which is a blood collection under the skin, and so we want to be mindful of that.
Okay.
Does that answer
Thank you. You did. I'm a little hesitant, but this is a very good presentation.
That's okay. It's a process.
Good information.
This hesitation is totally understandable, and this is a process. This is a conversation. I hope that none of my fellow doctors or healthcare providers assumes that just because I'm answering your questions and giving you all the information, and just because I got the shot means you're going to get the shot. No, this is a process, and I hope that everybody on this call today really at least has their curiosity piqued, and there will likely be many more questions remain unanswered, but then go ask those questions, right? Or Dr. Watson and I will come back on and have another discussion. This is going to take a while. Everybody's got their why they receive a vaccine. We're all in different phases of that why, and maybe or absolutely no. And so it's a matter of helping everybody come along with the information that they uniquely need in order to get to that yes and the shot in the arm.
I couldn't agree more with Dr. Simon. I know we're right at the top of the hour, Alicia, but I just want to remind exactly what she said. Our desire to dispel myths is not us saying that that asking questions is okay. It's a part of the process. One of the things we want to dispel though is that things like calling it Operation Warp Speed, and that we just want to dispel the myth that the speed in which this vaccine was developed did not mean that it was developed in a less safe way. The questions that you're asking are all the appropriate questions. You should be asking these questions. If you have some concerns, it's okay to have those concerns. Just make sure that they're getting answered by a healthcare provider or someone from the scientific community. That's all that we really want to make sure happens. So thank you to the NEIU and everyone else for creating this platform.
Yeah, thank you. I do want to address the pregnancy one more time, because there is a question in the chat, and I'm an OB. It is safe. Yes, you're right. Pregnancy was not outright tested, but pregnant persons and lactating persons are never included in clinical trials up front, almost never. It is a disparity in this country, actually. It's terrible. Trust me, I'm working on that at NIH level. But it is safe. But I will say it is a question between you and your provider. And if you don't get the right answers, the American College of Obstetricians and Gynecologists, ACOG, has good information, and we support the vaccine for pregnant and lactating persons. And also maternal fetal medicine, the Society for Maternal Fetal Medicine has a wonderful statement on that. But if you're a frontline worker or an essential worker or have chronic disease and you're pregnant, I do support getting the vaccine. And many of my healthcare provider friends have come to me and they have received the vaccine.
And getting vaccinated.
Doctor, for children over 12, you said it was safe?
No, it's actually not, it's not approved yet for 12. It's 16.
16.
For Pfizer, it's 16. For Moderna, it's 18.
Oh, okay.
Right now, both Pfizer and Moderna are enrolling 12-year-olds and older. So right now, so hopefully we'll get some data by the summer with respect to 12 and older, but we still don't know what to do with 11 and under.
Because I have 2 teenagers, so 13
Yes.
and 15, so not yet.
I got a few teenagers too. I have 4 kids. Yeah, it's rough. It really is. But thankfully, in general, when children get COVID, and I will say Black and brown children get COVID higher, and they do tend to have worse outcomes relative to white children. But it overall tends to be less severe disease than for older people.
Okay. Thank you, Doctor.
So I did want to just chime in and be mindful of everybody's time today. I know we said we would be ending around 1 o'clock. So thank you everyone for today's time. If Dr. Simon, Dr. Watson, if you're flexible and would be able to stay on to answer a few more questions, I'm happy to help continue facilitating. But I did want to be mindful of everyone's time. And we will be sharing some additional information that was shared today through email. So anyone that was on this call, we'll try and send as much information as we can. We'll kind of go through some of our unanswered questions and see if we can provide some more information on that as well.
In any event, if you get the vaccine or not, you've got to keep wearing the mask until we have more data. I know somebody asked me to say that in the chat, so keep wearing the mask. I'm sorry. We can pass this. We will. Promise.
So did any?
Thank you.
No problem.
Thank you so much. Very informative.
Yeah. I know somebody had a question about long-term data, where that's what phase 4 of clinical trials is. So these companies are continuing to collect data on all of us who have been vaccinated, and those who are in the trial will continue to be in the trial. So they're following all of us for a long time. And that's to ensure long-term efficacy, effectiveness, and see if we need a booster or not. Because again, we don't know with some of these variants, like there's a South African variant, for example, that's seemed to be more virulent or causes worse disease or more contagious. And so the companies right now are testing those new strains of coronavirus, those new types, mutated types right now with their vaccines. And so that data will be coming out as we go. Anything else?
Anyone else on the call that would like to verbalize a question that they had? Okay.
I have a quick question.
Go ahead.
Good morning, everybody. Well, afternoon at this point.
Good afternoon.
If you're taking it, you might have said it already and I missed it, but if you're already taking like a booster shot for like pneumonia or something like that, will the vaccine impact that, or do they work together? Will that be an issue?
No, I mean, we recommend it's better if you can at least wait a couple weeks, if not 3 weeks or so between vaccines, give your body a chance to develop the army it needs for that specific vaccine. So that's, you know, and if you had COVID already, that's something I didn't address. If you had coronavirus already, you still need the vaccine. There is no real recommendation about between the time you had it and when to get the vaccine. Some people are saying 90 days. That's probably about accurate. So from whenever you had that coronavirus infection, then you can walk out 90 days and say, okay, I can take the vaccine now. But you need the vaccine because we know that far and wide, the people who got coronavirus, their immunity to coronavirus isn't going to last, right? That may not be everybody, but for the data that we have so far, that immunity is not lasting for a long time. So definitely you need the vaccine. But then we also don't know how long the vaccine immunity is going to last. So you may need a booster, like we get flu shots every year, right? Does that answer your question, Kendall?
Yes, thank you, Dr. Simon.
Sure.
Thank you.
All right.
Bye, Dr. Watson.
Bye.
You guys
Thank
enjoy
you,
your day and
Dr.
be safe.
Watson.
I can stay on for a few more minutes. Is there anything else? I'm happy to try to answer questions. The hardest ones are when we don't have the data, and I have to say we don't have the data because we're still learning. It's so hard to build an airplane while you're flying it, and that's exactly what this is.
I had a question, Dr. Simon.
Sure.
So you mentioned obviously that, you know, we still have the data, and I feel like there's kind of this public expectation that scientists need to know it all, and that it's like their job to basically be able to tell everybody else what's happening. I was wondering what you think in terms of like education wise, like not necessarily correcting that thought, but like how we can do better in the education system, so that way that isn't the expectation, and that people actually understand like science is a process, and that just, you know, we don't have all the answers, but we are trying our best, kind of.
And I think that's on us. I think that's on public health practitioners, clinicians of all types, and scientists of all types. We have to be humble. I have a high humility. I am fast to say when I don't know the answer to something. I can say, even in clinic, when a patient asks me a question, I am fast to say, whoa, that's a great question. I don't know the answer. Let me go look it up, right? So it comes from this humility of, we don't need to have all the answers. We need to do the best we can with the information we have. And then we need to be humble enough to be able to acknowledge our shortcomings of our knowledge, whether it's personal because I didn't read enough, or I didn't, explore the answers to that question, or that it's in general that we don't have the general knowledge yet. And that is a really important point. And I think it transcends just science, but healthcare practice as well. Does that answer your question, Olivia?
Yeah, thank you.
I think we should probably host another one of these and maybe less of a presentation and more just open it up. And if people need to see some slides, we can always pop up slides.
I agree. I was kind of thinking that, but I figured we could kind of coordinate offline and then let everyone that was on this call know what we were able to work out and have it be more of a Q&A discussion type of situation.
Yeah, I think, Vesna had a question, asked that question. So
yeah, and we'll be trying to share the recording with everyone as well. So we'll do our best.
Right, this was recorded. Okay.
Yes. We will try our best.
Good, that's good. Well, I want to thank you all for
other questions. I do want to. Yes, thank you. Thank you everyone for coming today. We appreciate your time and staying a little over with us. Hopefully we can do this again and give some more information out for you guys. But we'll keep you posted and stay tuned for an email from us with more information.
Thank you all. Thank you all for joining and being curious. Appreciate it. I hope you spread the truths now. Stomp out those myths. Thank you all. Have a great day.
Bye. Thank you.
Ciao.